Good afternoon, everyone. So we have Dr. Robert Ohgami from Stanford University today with us. So he is going to give a talk about acute leukemia. So thank you, Dr. Ohgami, for spending your time with us. Thanks a lot.
Thank you for the introduction. So I'm happy to be giving this talk this morning about acute leukemia. And as you can see from the title of my talk, it's a little bit long, but the idea of it is really to give a pragmatic, approach to how to diagnose these acute leukemias. Really with the new understanding that we have from the 2016 WHO. Why don't we begin? So the goal of this, as I said, is one of the major goals here is really a strong general understanding here with key tips. And this is really a roadmap for the diagnosis of acute leukemia. We're going to go through this using key cases to understand acute leukemia. The goal of this is not to cover, though, every bit of tiny minutia in all of these acute leukemias, because that could be, easily a week-long series, whatnot. So acute leukemia, the word acute leukemia is a serious disease in blood. We all understand that acute leukemias can be divided into different lineages. Lymphoid lineage acute leukemias, the T-cell type, myeloid lineage, or if you don't fall into myeloid or lymphoid, you might fall into an ambiguous sort of category for an acute leukemia. These are known under certain headings to us as things like T lymphoblastic and B lymphoblastic leukemias, ambiguous lineages, and then also acute myeloid leukemias. And so the way that we classify acute leukemias is really using a combination of different modalities: morphology, phenotypes, genetics, molecular, and clinical information. And this is how we understood the diagnosis of acute leukemias, or the types of acute leukemias that we're dealing with according to the 2008 WHO. But as we're all aware, there's actually a new 2016 WHO for the classification of acute leukemias. And here you can see it here that there are many more categories. New things like early precursor T-cell lymphoblastic leukemias, IM21, BCR-ABL-like, B lymphoblastic leukemias. And in acute myeloid leukemia, we find that certain mutations have more relevance and allow us to call something an AML with recurrent genetic abnormalities, or RGA, I've abbreviated it here. And then a category of familial acute myeloid leukemias, which we were aware of, but become their sort of own entity. The significance of this, in some sense, is to understand that there are many more genetics plays much more importance in our diagnosis of acute leukemia. So how do you diagnose acute leukemia? Again, this is a practical, pragmatic approach to the diagnosis of these entities. So again, we use the 2016 now WHO, and it starts with morphology, right? And we all know this. It starts with the identification of blasts. And in general, to get to the category of acute leukemia, we require a cutoff, a threshold to be reached of 20% blast, right? And that allows you to start to think about, am I T lymphoblastic leukemia B or acute myeloid leukemia? What is a blast? Again, much of this will be familiar to all, but it's nice to go over this. Blasts are cells with fine, immature, smooth nuclear chromatin when you're looking at them morphologically. They're generally larger in size and have a high nuclear to cytoplasmic ratio. And so here's a cartoon diagram of a blast compared to a neutrophil. You can see the different condensation, and then you can also see it in real life, so to speak, on a picture on the right. There's ways to actually look at blasts, right, and kind of guess whether you're dealing with a lymphoid or myeloid blast. Again, this isn't going to be 100% correct. As you gain more expertise, maybe you'll be, 90%, 80% correct. So lymphoid blasts, what do they look like? They're often variable, small, medium to large in size, fine, moderately to moderately condensed nuclear chromatin, very high nuclear cytoplasmic ratios, occasional nucleoli, which is shown here. They look a lot like lymphocytes, but a little bit more mature. Myeloid blasts, in contrast, they are large in size. You can see the picture graph here. Very, very large in size. They have fine, even finer chromatin, more cytoplasm. They have large nucleoli, and then a lot of times you see granules corresponding to MPO. So it's just a little bit of a morphology blast. So understanding that in order to achieve an acute leukemia in general, we need 20% blast. Then we also have to pay attention to the immunophenotype. The immunophenotype helps to dictate to us whether we are T lineage, B lineage, or myeloid lineage, right? Or if we don't fit into any of those categories, if we are in an acute leukemia ambiguous lineage. And so there are certain markers that help to tell us whether we're B cell, T cell, or myeloid type. And I show them here. For B cells, CD19, 79A, 22, and 10. In general, you need essentially 2 or more of those markers. For T cells, CD3 is an absolute T cell marker. For myeloid lineage, MPO is an absolute myeloid marker. So essentially what that means, absolute marker is, lineage marker, is that if you have this marker, you are in that, you have at least that lineage to your name. And then there are other markers which help to tell us whether something is immature, and those are markers like CD34, or TDT, for instance. I just wanted to put this image here of some of these markers. As you can see this in the 2016, also the 2008 GOO, that there are different markers that allow you to call something myeloid T and B cell lineage, as I dictated before. The thing to be aware of for the T cell lineage, when you are looking at CD3 expression on your blast, the CD3 expression needs to be at least as strong as the background lymphocyte. So that's something that's very hard to find in all of the groups. So, immunophenotype can help us get into our categories, our larger subheadings of acute leukemia. CD3 again for T19, and then other markers for B and MPO and some other myeloid markers, if you have multiple numbers of them for acute myeloid. And then if you have combinations of those or none of those, you might enter into the acute leukemia and ambiguous lineage. Clinical and cytogenetic data is also very important for the subclassification of acute leukemia. Clinical information is in particular important for subclassification in acute myeloid leukemia. And I highlight this with the red box area. So Down syndrome patients may have acute leukemia, and they cause them to fall into a category of acute leukemia related to Down syndrome. If a patient has a history of chemotherapy, then that can cause them to enter into a subclassification of acute myeloid leukemia known as the therapy-related acute myeloid leukemia. If you have a history of a myelodysplastic syndrome in the past, then that can cause you to head into a subclassification of an acute myeloid leukemia with myelodysplasia-related changes. If you have family members and you have the germline mutations that would dictate that you fall into a familial AML, then that's also important too. And cytogenetics are also critical for, again, subclassifying our acute leukemias. And they play a relevant role in the lymphoblastic leukemias in particular, and also the acute myeloid leukemias. There are recurrent genetic abnormalities that are seen in both of those entities that can force you into a certain subtype. And we'll go through all of, well, I shouldn't say all, but most of these, or many of these acute leukemias with practical examples and how to deal with them, so to speak. So returning to morphology, this is important. Morphology is critical in assessing for background dysplasia. That becomes particularly important in acute myeloid leukemias with myelodysplasia-related changes. And so what is MRC, or myelodysplasia, right? And so erythroid, there's erythroid kind of dysplasia that you can see. You can see myeloid dysplasia. You can see megakaryocytic dysplasia in your cases, right? And in order to call something myelodysplasia-related changes in the subclassification of your acute myeloid leukemias, you need at least 2 lineages that have 50% dysplasia in each lineage. So that would be in erythroid, myeloid, and megakaryocytic. What do those look like? So erythroid dysplasia. So here's the essentially normal erythroid cells, precursors. And erythroid dysplasia is when you see irregular nuclear membranes in your erythroid precursors, as seen here. Megaloblastic changes or nuclear to cytoplasmic synchrony. So the nucleus maturing at a different rate than is appropriate with the hemoglobinization or the cytoplasmic maturation of cells, as seen here. You can see the chromatin is much more open for the amount of hemoglobin or pinkness or grayness of the cytoplasm of these red blood cells, or these erythroid cells. Ring sideroblasts are also a sign of erythroid dysplasia. And here you can see ring sideroblasts. And what is a ring sideroblast? There's actually a technical definition that you can follow. So it's classified as 5 or more granules, these sideroid granules, that represent iron that is abnormally inside of mitochondria or glossed up in there, surrounding 1/3 or more of the nucleus, right? So 5 or more of these little dots around 1/3 of the nucleus. A lot of times ring sideroblasts are associated with SF3B mutations. That was a recent time several years ago. What is granulocytic or myeloid dysplasia? So in the upper right, you see generally normal myeloid precursors. So granulocytic or myeloid dysplasia is irregular chromatin condensation and hypogranularity. It's very easy to pick out hypogranularity. Abnormal chromatin condensation can be a little bit more tricky, but I can tell you that these are also abnormal nuclear have abnormal nuclear features. So what is megakaryocytic dysplasia? Megakaryocytic dysplasia is hypolobated nuclei. So here you can see that. This is a smaller megakaryocyte. And also megakaryocytes that have separate nuclear loads. This one happens to also have separate nuclear loads. This one does here too. That is a sign of dysplasia in megakaryocytes. So now that we have the general background of morphology, understand lab, morphology to understand myelodysplasia-related changes, understanding of immunophenotypic features for being able to call lineages, and a little bit of a roadmap that I put out there. It is how to approach the diagnosis of acute leukemia. Let's go over actually how we go about doing this. And so the way to do this is really to use this roadmap that I put together in this page here. And essentially, you want to start off with saying you have 20% blast. You have 20% blast, then you enter into acute leukemia land. And then you approach it from the sense of what are the immunophenotypic features of these blasts? Do they have CD3, CD19, and other markers, or FEO, or other myeloid markers in combination? And that can take you into these different categories here. Either TED or myeloid lineage, or neither. And then you evaluate the clinical history of the patient to help you subtype and also cytogenetics. And so let's go through this algorithm that I just mentioned, which I've made an extra page here for evaluating. And this is what the algorithm looks like. And we'll go over this again and again with different examples. And through those examples, I will also go over many of these important entities. So that's the way that we can gain knowledge and have fun with this. So the way to use this roadmap is to go down the roadmap, right? So you ask yourself, are you in acute leukemia? What's your immunophenotype? Trying to head along different roads, and then continuing down these different entities. So looking down through the hemoplastic, asking yourself first, are you early precursor, or are you just sort of a standard hemoplastic? And the same thing with hemoplastic. First asking, are you a recurrent genetic abnormality type of BALL? Do you have the type of cytogenetic abnormality? not continue down the sheet. And the same thing goes with acute myeloid leukemia. You continue to move down the sheet. So once you have decided you're in acute myeloid leukemia land, you ask yourself, are you down to the general type of acute myeloid leukemia, therapy-related one, or recurrent genetic abnormality, a myelodysplasia-related change, or if you're not there, then you end up in the NOS category or not otherwise specified kind of acute myeloid leukemia, which is, I like to refer to those as kind of garbage acute myeloid leukemia because we don't have more genetic information or not understanding. So let's, again, this is a practical approach, and we're gonna gain our understanding of these entities and also become experts in acute leukemia by going through these cases. So the first case is a 4-year-old with difficulty breathing and a high blood cell count. So peripheral blood smears performed, and this is what the blast look like. And I tend to lectures sometimes to be a bit repetitive to try to hammer in information. So you look at these blasts here, and these blasts are small to medium to large in size. They have very high nuclear to cytoplasmic ratios. They have fine to moderately dense nuclear chromatin. They have no cytoplasmic granules. And so they look kind of like liquid blasts. Bone marrow aspirates smears form. You see the blasts here. They look very similar to what you saw before the peripheral blood. And H&E is performed, and you can see blasts on the H&E slide here. And this is what blasts look like in an H&E. Fine chromatin is see-through chromatin, so rather than having very condensed dark chromatin, like for instance this cell over here, these blasts, you can see a lot of white spaces between them, and they also have some nucleoli. Flow cytometry is performed, and you can see the plot here, and what you notice right away is that there's CD3 expression on these blasts, and TDT, and no 19. And then cytogenetics are performed, and I can tell you that there's a normal karyotype for the patient. And so what's the diagnosis here? So again, I would encourage you to use this roadmap that I developed to try to diagnose these acute leukemias. I'm happy to distribute it to people who are interested later, or you can see it here and use it. And so we start at the top. Do we have 20% blast? Yes, we do. We have a lot of blast in peripheral blood. And then we start to ask, what antigens do we express? Do we have CD3 expression on our blast? And we do. And so now you head down the roadmap and say, okay, now I'm in T lymphoblastic leukemia, right? So the diagnosis here, broadly speaking, is a T lymphoblastic leukemia, right? But you look more carefully at the flow cytometry, and this is how, again, we're going to build in sort of knowledge. And you notice that there's an interesting immunophenotype for this patient. This patient has blasts that are CD1A negative, that are CD5 negative, and are CD8 negative, as well as expressing stem cell markers, CD34, and also some sort of myeloid associated antigen, CD13. And so that actually helps to push us into a different category, a newer category, according to the 2016 WHO, something that has been recognized more recently. An entity called early T-cell precursor acute lymphoblastic leukemia. So this is a sub-classification of T lymphoblastic leukemia. This early T-cell precursor acute lymphoblastic leukemia, again, they have a characteristic flow immunophenotype or immunophenotype. They lack CD1A, they lack CD8, they start to not have so much CD5, and they express stem cell markers. And these tend to have a lot of genomic instability. And the importance of this category, and I'll talk about that in a second, is a couple of things. So on the genetic level, what's interesting about these early T-cell precursor acute lymphoblastic leukemias is they have a lot of times genetically a myeloid leukemia signature. It's very fascinating. You can read that paper. There are other papers too. But clinically, it's very significant because these patients, as you can see here, tend to have a poor overall survival and poor event-free survival. They relapse frequently. So that's why this category came, sort of more to the fore, and also it's genetically kind of more distinct. So based on the flow, again, negative for CD1A, negative for CD5, negative for CD8, but it does have CD3, right? And having stem cell and myeloid associated kind of markers is an early T cell precursor acute lymphoblastic leukemia, and your clinicians will be very happy to that you diagnose that so that they can intervene appropriately. So the summary here, T lymphoblastic leukemia expresses CD3 and it will have mature markers like TT. And it's important to be aware of this new category in the 2016 WHO, early T cell precursor acute lymphoblastic leukemia, which has worse behavior, right? So case number 2 is an 18-year-old with easy bruising after a soccer game. And you look at a peripheral blood smear and you see blasts here. And the blasts are small, medium, larger in size, I'll tell you. And they have fine to moderately condensed chromatin, very high nuclear to cytoplasmic ratios, not significant cytoplasmic granules. And so they look a lot like lymphoblasts. And there's bone marrow aspirates here that looks that's performed that looks a lot like other slides, but these blasts have high nuclear cytoplasmic ratios, same thing as the peripheral blood. The HG is performed, the blasts are here, and again, blasts show these blasts show finer chromatin, as indicated by being able to see through their chromatin. There's a lot of white space in the nucleus, as opposed to a more mature and condensed lymphocyte, for instance, here. The dark. The flow cytometry is performed, and the immunophenotype is shown here. You can see that these blasts express CD19 and CD79A, so B cell markers, and they have GDT, an immature lineage marker. And so the immunophenotype here is that of B cell lineage, right? Cytogenetics are performed, and the cytogenetics actually show a 922 translocation, as shown here. And so what's your diagnosis here? Well, again, I return to the roadmap to understanding where to go with this. So the first question is, do we have 20% blast? Yes, we do. So we're in acute leukemia land. Do we have CD3 expression on these blasts? No. Do we have 19 expressions, 79A, B cell marker antigens? Yes, we do. And so you head down the roadmap towards lymphoblastic leukemia. And then again, you continue to go downward in your roadmap towards the bottom page, and you ask yourself the first question: is this a B lymphoblastic leukemia with recurrent genetic abnormalities? Is there a certain cytogenetic or genetic abnormality that you see? And yes, there is. There was the 922 translocation. The BCR-ABL. And so the diagnosis here is really straightforward using this, again, roadmap, that this is a B lymphoblastic leukemia with the 922 translocation. So the summary here is that from the case is B lymphoblastic leukemia with the 922 translocation, and you can show expression of myeloid antigen. So this gives us a little opportunity to talk about B lymphoblastic leukemia. So there are different categories of B lymphoblastic leukemia. B lymphoblastic leukemias with recurrent genetic abnormalities is a subheading under BALL. B lymphoblastic leukemia not otherwise specified is if you can't get into any cytogenetic abnormalities or genetic abnormalities. And these particular recurrent genetic abnormalities have different things that are associated with them. So for instance, the 922s and MLLs tend to have myeloid-associated antigens that you express in them, like 33, 13, 15. MLLs tend negative. Other ones, like the 514 translocation seen in BALL, they may have a lot of eosinophils due to the translocation between interleukin-3 and IgH, which stimulates the EOs. And then the other thing actually I wanted to bring up, and what the color coding indicates here is that certain ones of these, the reason for these subclassifications is there are features associated with the clinical presentation, with the immunophenotype of these different types of cytogenetic abnormalities. And there's also prognostic differences. So the ones that are highlighted in red tend to do worse. The ones that are highlighted in kind of blue tend to do better. So there are even newer 2016 two categories within the recurrent genetic abnormality category of B-ALLs that are important to be aware of. One of them is this new category of B-lymphoblastic leukemias, BCR-ABL-like, and this is from Vanderveer's paper in Blood that shows that these types of B-ALLs that are BCR-ABL-like, they tend to have a higher incidence of relapse, so the patients don't do quite as well. And you can identify these cases by actually looking for, not just genetically looking for them, but which may be difficult for some labs, but you can look for high CRLF2 expression, and that actually can be done by flow cytometry. So this will be something that we will all be diagnosing more because it's clinically significant. And then there's another category of BLLs, or BLLs with intrachromosomal amplification of chromosome 21. And these BLLs have intrachromosomal amplification of a region of chromosome 21, and that's the region around RUNX1. So if you do your RUNX1 fish, you would see that there are 3 or more signals potentially on one chromosome, in particular chromosome 21. The significance of this category is again that these patients tend to do worse. They relapse quite frequently. With high intensity chemotherapy though, adjustments, they'll actually perform quite well. So you can read Warren's paper in Blood for that original sort of finding. So let's move on to a different case and continue to build our knowledge of the 2016 WHO and other categories in it. So case number 3 is a 28-year-old woman who has night sweats for a week and PKA and bruising. A clinical blood smear is performed, and you can see that there are abnormal cells. These look like peculiar blasts or perhaps promyelocytic. They have finer chromatin. They have quite a bit of cytoplasm. You also see that there are granules, lots of granules, and also outer rods, elongated needle sort of shaped violet needles here. And I showed on the side here sort of the CBC for the patient. They have an elevated white blood cell count. And then also you find out when you do your coagulation studies that the patient has a high D-dimer level or D-dimer unit level of greater than 19,000, so very high. Pulmonary aspirin smear is performed. This looks the same as the peripheral blood smear. You see these abnormal cells, very densely granulated cytoplasm or hypergranular. And you might say also that if you look at the nuclei, they have sort of a butterfly shape, which is very characteristic of this particular leukemia. The core biopsy is performed, and this is what the blasts look like. In the core biopsy, they're very large in size. They have fine nuclear chromatin that you can see through compared to more condensed nuclear chromatin here with my mouse. Flow cytometry is performed, and what do you see? Well, you see that these blasts have very high side scatter, and that's because side scatter in flow cytometry is measuring internal complexity or granularity of the cells. And these cells have a lot of granules. Very high levels of MTOs are expressed on these blasts. These blasts are negative for HLA-DR and generally negative, mostly negative for CD34. And that's indicative of a particular type of acute leukemia. You do cytogenetics, you find that there's a 15-17 translocation in this patient, which is diagnostic of this entity. And so what's the diagnosis here? Again, we can return to our roadmap and say that we saw 20% blast in the peripheral blood bone marrow. So we're in acute leukemia land. There was no CD3 expression. There's no 19 expression. There's MTL expression. So we're into the category of acute myeloid leukemia. And then we continue down the page asking ourselves the question, is this a myeloid proliferation or acute myeloid leukemia Down syndrome? No, the patient doesn't have a history of Down syndrome. Is this a therapy-related AML? No, there's no history of therapy. Is this an AML with recurrent genetic abnormality? Do we see any of these genetic kind of findings in independent acute myeloid leukemia? And yes, we do. We see that 15-17 translocation. So we know that the diagnosis of an AML with a 15-17 translocation or acute promyelocytic leukemia. The treatment for APL is, most of us are aware, is ATRA or all-trans-retinoic acid, which will help to differentiate the blast, the indication of the problem. It's important to be aware that in APL or acute promyelocytic leukemia, there are different types, or two variants, morphologic variants to be aware of, a hypergranular variant and a micro or hypogranular variant, as shown here, these two types. So the hypergranular variant, you see lots of alrod, lots of granules in the cytoplasm, whereas in the microgranular variant, it's hard to see the granules as much and whatnot. But in both of the variants, there are, beautifully I show these butterfly sort of shapes. The flow cytometry findings can be distinct in these two types. And so flow cytometry for the hypergranular variant, or more classic acute promyelocytic leukemia, the important immunophenotypes to remember is they're 34 negative and HLA-DR negative. The cytogenetics will show the 15-17 translocation, and they may have a certain breakpoint region, breakpoint cluster region split between PML and RIRA. We'll go over that in a second. Flow cytometry for the microgranular variant is often distinct. These not only look unusual for an acute promyelocytic leukemia, they don't look so promyelocytic in the sense of having granules and whatnot. That the flow cytometry findings may be odd too, in that they will have 34 expression, DR expression, and they may express CD2, but that's different from the hypergranular variant, which lacks 34 and HLA-DR. The cytogenetics can be interesting in the microgranular variant in that they may not always have the classic translocation between 15 and 17. They may share it with another partner. So I brought up this breakpoint cluster region, or BCR, and there are three different breakpoints that we see, BCR 1, 2, or 3, and these are called out based on where the breakpoint is in the PML sort of gene or area. And they go in larger size as you go down. And so breakpoint cluster region 1 tends to be the ones that you see in the microgranular variant, and then breakpoint cluster region 2 and 3 tend to be in the hypergranular. It's just a little bit of extra minutia that I threw in there. So APLs are often, or acute promyelocytic leukemias are often associated with disseminated intravascular coagulation or coagulopathy, DIC. You all are aware of that, where you'll see lots of schistocytes, where these fragmented red blood cells and spherocytes. These schistocytes representing fragments of red blood cells because there's fibers being laid down and the red blood cells are being shorn apart. The spherocytes are an endpoint of schistocytes. Schistocytes, after they mature over time, that look like this, these irregular shapes, will eventually round up and become balls just by the physiometric sort of properties. So the DIC is frequent in APL, and almost always the D-dimer level, I encourage you to look at this, will be above 19,000 in APL D-dimer units, or if you use fiber equivalent units, fibrinogen equivalent units, it would be 3.8 for that. So the D-dimer level is high in AML, but it can also be high, in acute promyelocytic leukemia, but it can also be high in AML with monocytic differentiation. So a very high D-dimer level, basically at the upper threshold level of whatever kind of assay you're using, is sensitive for acute promyelocytic leukemia, but it's not specific. So it's useful to initially figure out if you might be dealing with detail. Our clinicians use that a lot here now. So the summary of case 3, acute promyelocytic leukemia is associated with disseminated intravascular coagulation. There are two variants, hypergranular and a micro or hypogranular variant. The 15-17 PML RIRA translocation or RIR alpha is associated with APL, which is diagnostic for it, and it usually responds to patch or all transretinoic acids unless you have a variant translocation. The hypergranular slow immunophenotype is CD34 negative, HLA-DR negative, and the microgranular slow immunophenotype is abnormal in the sense that it may be 34 positive, CR positive, and F2. So the next day, this case develops, or your service develops, and the colleague comes to tell you that a patient with 10% blast in their marrow is in the hospital, and you see the marrow aspirate, and you see blast, and the blast looks a lot like that other acute promyelocytic leukemia case, the hour and whatnot. But there are less than 10% blast in this case, or 10%. Flow is done, and the flow looks a lot like that other case, and then you have blasts that have high size scatter, indicate granularity or internal complexity in the cell. There's high MPO expression. There's no DR, there's no 34. Cytogenetics are performed, and there's a 15-17 translocation. And so what do you tell your friends? You have a case where there's less than 10% blast, and you have all these other kind of findings. So the question is this AML with 10% or less than blast? Yes, absolutely. This is still acute promyelocytic leukemia or AML. And that's because there are certain translocations or inversions that don't need 20% blast. 15-17 translocation, the 821 translocation, and inversion 6 or translocation 6-6, 16-16 doesn't need 20% blast. If you have even a low level of that translocation in your marrow, you're going to take off and become AML. So the clinic, you need to call it just AML with less than 20% blast. The translocation and whatnot are there. So case number 4. Again, we're building our knowledge and understanding of acute leukemia through all these cases. It's a 60-year-old man who has a history of fatigue for 3 years. And here's a picture of the peripheral blood. You can see their blasts here. These blasts are very large in size. They have very fine chromatin. They have big nucleoli. They have high nuclear cytoplasmic ratios, but maybe more moderate amounts of cytoplasm. And then maybe you see granules here and there. When you look at their peripheral blood, you also notice that in the background that the neutrophils look dysplastic. This is a hypogranular neutrophil that also has palmaroid features in that there are its bilobes. The platelets are hypogranular and large, also a dysplastic feature. When you look at the bone marrow aspirate, the megakaryocytes look abnormal and dysplastic. Erythroids look dysplastic with irregular nuclear membranes and some more megaloblastic kind of changes. And there are blasts. And the bone marrow core biopsy is performed, and again, you see all those findings that you saw in that bone marrow aspirate, and the blasts have fine chromatin that you can see through their chromatin, this white scale space, this big nucleoli. Flow cytometry is performed, and you identify there are blasts there that have 34 expression. They have 1333 expression and MPO expression. And then cytogenetics is performed, and there's a deletion 5q identified. And so what's your diagnosis here? Well, again, we return to our roadmap. We see that we're dealing with 20% blast, so we can start to head into acute leukemia land. We don't have CD3 expression on our acute leukemia. We don't have 19 or any of these other B-cell markers. But we do have MPO, and so we're in the acute myeloid leukemia area. And now we can head down to try to continue to subclassify our acute myeloid leukemia even further. So we can ask ourselves the question, does this patient have Down syndrome? No, there was no history of that provided. Do they have a history of being exposed to chemotherapy or radiation? No. Do they have a recurrent genetic abnormality? No, they don't have any cytogenetic abnormality or mutation that would push them into that category. Do they have an indication to be in an acute myeloid leukemia with myelodysplasia-related changes? And yes, they do. They have myelodysplasia-related cytogenetics as well as actually multi-lineage dysplasia. And so the diagnosis here is an acute myeloid leukemia with myelodysplasia-related changes and multi-lineage dysplasia. And this patient probably had a history of myelodysplastic tumor MDS because that cytogenetic finding of a deletion 5q is very typical for an MDS. Usually doesn't just appear de novo. And so when you talk to your clinician, developing this case further, that and ask them what's going, what happened to this patient, the past and whatnot, clinician admits that the patient had cytopenias for many years. So indeed, they probably did have MDS. So I'm going to ask a question here and cover this, so to speak, is what's the significance of multilineage dysplasia? So that morphologic multilineage dysplasia that we see in acute myeloid leukemia. So dysplasia in 2 lineages, each lineage with 50% or more dysplasia in a particular line. Well, there are some papers in the past by Weinberg and colleagues that identified that multilineage dysplasia may portend worse prognosis. Even with normal karyotypes, so your genetics are not remarkable, you have a lot of morphologic function, then maybe it's worse for you. There have been subsequent papers, several that have come out that say that basically multilineage dysplasia in the setting of understanding genetics and very well has absolutely no impact on patient outcomes. So that remains to be delineated further, but it appears that morphology is starting to become less important as genetics starts to emerge. So summary number 4 here. For the category AML with myelodysplasia-related changes or acute myeloid leukemia with myelodysplasia-related changes, a history of MDS or myelodysplasia, myelodysplastic syndrome can get you into the category. There's 3 ways to get into the category. History of MDS, certain cytogenetics, such as the 5q deletion, or there are other things you can look in the WHO table about all the different cytogenetics, or multi-lineage dysplasia, so 2 lineages with 50% dysplasia in each of those lineages. So our case number 5, again, continuing to build our understanding of the classification of acute leukemias. Here's a 55-year-old woman with bleeding gums. She comes in and you look at her peripheral blood smear and you see blasts. They have very fine nuclear chromatin, prominent nucleoli. They're very large in size. They have some moderate amounts of cytoplasm. Maybe there's some granules that you can see. You look at the granulocytes in the background and platelets to see if there's dysplasia. You don't really see any. It's just blast. And when you look at the blast even more carefully, you find that they have this interesting feature that people have described as cup-shaped nuclei, where there's this paler area here, almost like forming a cup here, blast here forming a cup, another blast here forming a cup. So cup-shaped nuclei, paler area here, with a little line going around like a cup shape. And that's characteristic actually of this type of acute myeloid leukemia morphologically, although you can see it randomly and other things. But a lot of times it tends to stand out. So the bone marrow aspirate smear is performed, and there's blasts here. You can see that there's abnormal large shaped blasts like the peripheral blood smear. Core biopsy is performed, and this is what the blasts look like. So again, they have that finer chromatin. You can see through their chromatin, a lot more pale. And they're big nucleoli in these blasts. Immunohistochemistry is performed, and I can tell you that these blasts are MPO positive. Cytogenetics is performed, and there is no abnormality to normal karyotype. Molecular is done, so more sequencing is done on the patient, and you find that there is an MPM1 mutation. And so what do you do with that? Well, so what's the diagnosis here? So we follow our roadmap here. We have 20% blast. So it allows us to get into the acute leukemia category. We don't have CD3 expression, so we're not dealing with the hemoglobin leukemia. It doesn't have any B cell sort of markers, 19 in combination with other markers. But we do have MPO expression. And so we're in acute myeloid leukemia land, and then now we head down the chart. Do we have a patient with a history of Down syndrome? No. Do they have a history of therapy, some sort of chemotherapy or radiation? No. Do they have a history of, or do they have a recurrent genetic abnormality? So any of these things here. This is important to go over. This is a little different than the 2008 WHO. But now, in the 2016 WHO, mutations of NPM1 get you into the category of AML with recurrent genetic abnormalities. There are other genetic mutations that also get you into that category. RUNX1 mutations and also CBK alpha, biallelic CBK alpha mutation takes in there. So that's important to just be aware of. The diagnosis here, using the roadmap, is an acute myeloid leukemia with a mutated NPM1, right? And again, in the old days, this actually would have been called AML, not otherwise specified, and then we might have noted that it has FAB or French American British classification morphology of sort of M1 morphology. And so what is the FAB or the French American British classification? Because this, even if we are getting further and further away from it, some people still sometimes, it appears in reports, people sometimes use it. The FAB categorization was really based, it's an old classification of AML, so it's really was based on a lot of morphology, a little bit of biochemistry and whatnot. And it was based, so there's these different categories, M0, M1, M2, sort of indicating how much differentiation you have. M3, the FAB was ATL actually. Myelomonocytic differentiation, actually then M4, M5 is monocytic differentiation, M6, erythroid, and M7, megakaryocytic. So I only bring this up because again, you may see it here and there in reports, sometimes clinicians ask for it. But you can also push back if your colleagues, clinical colleagues are asking, you to stuff classified according to FAB, and I understand according to trials that we need it, but what's the significance of the FAB criteria in the era of our new subclassification, the WHO, the 2008 even, or the newer 2016, which people should be using? And you can see this nice paper from Walter and colleagues from blood, but basically it's not significant. You can see all these different subclassifications of the FAB types, and they don't separate out, right? So the patients don't, there's no significance. But what is significant? Well, molecular is significant. So different mutations can help prognosticate patients accordingly. So if you have biallelic mutations of PDK-alpha, it is better for patients. And if you have NPM1 mutations, it's better for patients. But if you have FLT3 internal tandem duplication mutations, that's bad for patients. This is why, actually, in some sense, that the 2016 WHO decided to make a subcategory of an official category for biallelic mutations of PDK-alpha and NPM1 mutations within the category of acute myeloid leukemias with recurrent genetic abnormalities, because they are genetically defining, pushing into a certain way about the AML, and also clinically they make a difference. So summary 5, PDK-alpha is good prognosis, just go over genes a little bit. NPM1 is good prognosis, and FLT3 is poor prognosis. So if you remember that FLT3 is poor prognosis, that will help you remember. FLT3, though, just to mention this now, does not define a category of AML. So you don't say the subcategory of this is an acute myeloid leukemia with a FLT3 mutation. It's not a who-defined subcategory. It does mean this patient will do it in general. So case number 6, a 70-year-old woman with fatigue for 3 years. She's had a history of treatment for breast cancer. You see patients not infrequently like this. Radiation and chemotherapy. And a peripheral blood smear was performed on the patient. You can see blasts here. They're large in size. They have very fine chromatin. They have big nucleoli, high nuclear cytoplasmic ratios. Maybe you see some granules in the cytoplasm. Bone marrow aspirate shows those blasts again. Similar to the peripheral blood, very fine chromatin, very large in size. Some nucleoli here and there, maybe some granules. Bone marrow core biopsy looks as follows. The same thing as aspirate, lots of blast, that fine chromatin, that see-through chromatin, where it's much more pale kind of chromatin. And flow cytometry is performed, and you can see that these blasts are here at express of 1333, some CD4, and immunochemistry is performed, and the blast express MTO. Cytogenetics is also performed, and there's a complex karyotype for this patient. They have 3 or more cytogenetic abnormalities. And so what's your diagnosis here? Again, we can return to our roadmap. So we have more than 20% blast, taking this into acute leukemia land. We don't have CD3 expression or B cell markers like 1979A, T or 22, but we do have MTO expression. Taking it into acute myeloid leukemia. Now we head down our curve trying to figure out what subclassification of an acute myeloid leukemia are we dealing with. We don't have a patient with Down syndrome, so we don't consider that diagnosis. But we do have a patient with a history of therapy, chemotherapy, and radiation therapy. So this is an acute myeloid leukemia, a therapy-related acute myeloid leukemia. So the diagnosis here would be acute myeloid leukemia, therapy-related. And the summary here is that therapy-related acute myeloid leukemias that occur after chemotherapy or ionizing radiation, typically several years after. Many years after. And frequently they show a complex karyotype, so 3 or more chromosomal abnormalities. And that makes sense in a way, if you want to think about this sort of teleologically or whatnot, that, if you're getting a lot of bad stuff hitting your DNA, you're gonna lead it all kinds of different ways, cause different translocations all at once. And there's often profound multi-lineage dysplasia in these patients when you look morphologically at them. So, I'll say that somebody comes to talk to you and says that it tells you, my friend had breast cancer, so this is developing this scenario further, and was exposed to radiation, and now has AML, and had also cytogenetics performed, which showed an 821 translocation. That typically would get you into an AML with a recurrent genetic abnormality, right? So, the patient should do really well. That's the question, right? Yes, no? And you also are aware that that 821 translocation, because we sort of briefly covered this before, that's associated with better prognosis in general, right? So you might expect, and this other person did, that the patient should do really well. But actually, in fact, no. The history of therapy trumps the good translocation. And that's why when I made that roadmap, the way it's dictated is we'll get you to the right diagnosis by not considering recurrent genetic abnormalities first. So therapy trumps the good translocation. And there's a nice paper in AJCT by Christopher, if you want to read it about, in particular, the 821 translocation therapy. So case number 7 is an irritable 2-year-old with a single crease across their hand, a semi crease, an almond-shaped eye, a flat face. You may, a lot of us don't see patients anymore, but that may indicate something to you that you can remember from medical school or whatnot. But the peripheral blood smears performed. You can see a blast here. It's a very large blast, has a big nucleolus, fine chromatin, and also it's interesting that this blast has these interesting cytoplasmic blebs. A bone marrow aspirin is performed, and this is what those blasts look like. They're very large in size, and maybe if you look hard enough in other areas, you can see that there might be blebs. When you look at the H&E bone marrow core for this patient, it's very interesting. You see a ton of very abnormal cells. Some of them look like blasts, typical blasts. A lot of them look like very unusual megakaryocytes, in fact, so maybe more mature ones. And there's a lot of fibrosis. That's very typical for this. Flow cytometry is performed, and you identify a 34 positive population that has some 56 and some CD61, which could indicate megakaryocytic type of differentiation. CD41A is also seen on these blasts, and again, CD41A can be a marker more of megakaryocytic type of differentiation. Maybe matching what you kind of saw morphology. IPOX is performed, and these are MPO positives. Cytogenetics is performed, and you find out that there's a constitutional trisomy 21 in this patient. And so, what's your diagnosis here? Well, we have 20% blasts. We're in acute leukemia land. There's no CD3 expression, so we're not dealing with the hemoplastic leukemia. There's no B cell markers, we're not in hemoplastic land. It has MPO, we're in acute myeloid leukemia land. And then now you head down the chart, right? And when you start heading down the chart, ask yourself the first question, is this a patient with Down syndrome? Do they have an acute myeloid leukemia related to Down syndrome? That's where we stop. Yes, the patient has Down syndrome and has an acute leukemia. So the diagnosis here would be a myeloid leukemia associated with Down syndrome. What's the prognosis? So we can go into a little bit more depth about this area. So the prognosis for these patients is interesting. Down syndrome patients that get an acute myeloid leukemia do well, with certain sort of caveats. Young Down syndrome patients do well. You see that in the curve here. old Down syndrome patients, greater than 4 years old, they do very poorly, right? They sort of behave like everyone else with acute myeloid leukemia. And so this is going to develop this case a little more. There's more bad news for the family for the continue this scenario. There's a sibling that comes in from this family that has trisomy 21 and also develops AML. And this sibling is 12 years old, right? And I just gave you some information to be able to use here. So what do you tell them? This is a 12-year-old, has AML, has a history of Down syndrome. What are you going to call this? What are you going to tell the patient? Well, I just told you this information that young Down syndrome patients do well, but old ones don't do well, right? This patient is above 4 years old or 12. You can see by the curve, basically these patients just, very aggressive for them. So what do you tell them? Well, you tell them, and what do you call it, right? You should just call it acute myeloid leukemia, and you probably should have a comment in there really describing that, explaining sort of the issue here, and it's going to behave more aggressively. And the reason for that is because if you call this is my, a lot of other people say that if you call it acute myeloid leukemia related to Down syndrome, the clinicians may not understand the caveat that this is going to behave aggressively and think it's like the way that the ones that act in young people, right? Because they know that that subclassification within the WHO. So it's important to bring that out and draw that out and be aware of it. So aside from far for this. So patients with Down syndrome can get something that's not leukemia, that's basically a myeloid proliferation that's transient and going to go away. So that's why actually the official category for subheading, if you look at the 2008 and 2016 WHO, for these, is there's sort of a larger subclassification. Myeloid proliferation is related to Down syndrome, and that's because the myeloid, some of these will be quite transient, and that's when the patients are young in age, so generally less than 3 months. Patients can come in and have something that looks, for all the world, like acute myeloid leukemia. If they're young and it's the first time, it will probably disappear. It invariably will. In an older patient, 1 to 5 years old, they're going to have that myeloid leukemia that's not going to go away. It's not going to be this transient sort of form. And so it's very important to separate those things out. And when it's a transient form, we call it this transient abnormal myelopoiesis. So what is this? I sort of said it again, but said it before, but I'm going to redictate this, that it looks like an acute leukemia or an MDS in a Down syndrome patient, but the patient is young, so less than 3 months, that's what you're going to see. And it's going to go away, right? And the clinicians are very aware of this, pediatricians, and so you don't want to treat it, you want to let it go in its own. So case number 8, 20-year-old with delayed, this is the last one. This bone marrow aspirate is performed. You see that there are lots of blasts here. They're large in size. The findings are from flow cytometry performed. What is a blast expressed? The blast has some 79A expression. They have 19 expression. They have some 11C and CD64. That's a little bit strange, right? I'm taking you to a little bit different territory here. And so now you are trying to figure out what to do with this, because it's odd. They have B-cell markers, myeloid markers. So maybe you look in the 2016 how to deal with this, and you find a table that tells you about how to call things myeloid T or B-cell lineage. And you find that this patient meets criteria for having B-cell lineage. They have 19 expression, 79A, and they also meet criteria for falling into myeloid lineage. They have 14 and also actually 11C. The circle jump. The wrong antigen. So how do you deal with this? Well, so we'll figure this out. The cytogenetics are performed, and we find that there's a 411 translocation or MLL gene mutation, which may make you feel like you know where to head with this, or mixed lineage leukemia gene translocation. So we have 20% flat in our roadmap. We're in acute leukemia land. We don't have D3 expression. We do have 19 and 79A expression and 64 and 11D. So you could be confused. Well, do I go to AML? Do I go to B full plastic? What you should do in that case is you can't fit into any category of those major 3 nice categories, is you end up in the acute leukemia, the ambiguous lineage land. The diagnosis here, this just briefly, if you sub-classify even further, would be a mixed phenotype acute leukemia B myeloid, it has B and myeloid antigen, and it's got that 411 translocation. This is just very briefly that the mixed phenotype leukemias are very confusing. There's actually older criteria, the EGO criteria that can tell you how to try to subclassify these. You should use really the 2016 WHO because that's what people use. But my point of showing this and also this other paper from that looks at how to classify mixed phenotype acute leukemias is that it's very difficult and it's confusing and it's hard. People have their opinions. So the final summary here is that now we can use the 2016 WHO, which will be released soon, officially, completely. And it's used this algorithm, right? Because it's very easy to get to the correct diagnosis with it as a guide. And again, if you need more information or whatnot, feel free to, or you have questions, feel free to email me. And then thank you. That's it.
Thank you, Dr. Ohgami. Thanks a lot. We appreciate it.
So, Dr. Ohgami, I have one question regarding the case number 3, the promyelocytic leukemia. You mentioned that sometimes we can be diagnosed, if we have the right cytogenetics, we can diagnose that type of leukemia with less than 20% of blasts. My question is, how do you approach that in the meantime while you wait for the cytogenetics, since this could be life-threatening for the patient? Is the same risk will apply for DIC?
Yeah, so we've had patients that have come through and have sort of, people might consider it because it's less than 20% blast, an oligoblastic state of acute myeloid leukemia. And that exactly had this scenario where, in the sense of 10% blast, and the blast by flow looked like APL, right? And you would see that very high size scatter, a lot of MPO. The patient, one of the patients that going more in depth did have DIC, actually, was experiencing DIC. And so the clinicians, went ahead with treating with Atrin. That's never a bad thing if you are suspicious, because it makes such a profound, difference for the patient. But I think also that for the majority of us too, that, or majority of institutes and places that we have access to rapid fish, right? So you can generally get the fish to get done in a day or at the most, 2 days, so that it won't make too much of a difference. But that patient did call out actually, and he had told them, do after, even though we don't have the fish right away. And it did end up being that. So.
All right. Thank you very much, Dr. Ohgami.
Thank you, Dr. Ohgami. Thanks so much.
Thank you.